So I'm going to reformat the OLIF as a pre-Psoas approach to make it more generic, because there's different ways to do it, and OLIF's one, and there's other ways to be anterior than Psoas. And but I have to admit, I occasionally do go through that muscle, so I'm not pure OLIF. There are cases when I do use it. It's not good. Hang on. So my talk is the pre-Psoas approach, but the goal here is to summarize the actual pre-Psoas approach benefits, and then of course along with benefits come complications, and we all want to know about both. And so this is kind of an overview, not a technique talk about how to do it. There's lots of cases we've done that with, so we can go to the library, get those, the excellent Seattle Science Library. Push the button. You have to use the mouse. I don't know how to do that. So the disclosures are here. How do you do this? Push the button. So when is OLIF ideal? Multi-level degenerative disease, stenosis, spondylolisthesis, coronal imbalance, sagittal imbalance, pseudoarthroses, infection, adjacent segment disease, trauma, tumor, revision surgeries, just about everything. And this is also true of lateral surgery, not just OLIF. But I think OLIF in particular has some additional advantages. But when do you not use OLIF? You know, if you've got a prior 5-1 ALIF or OLIF, the iliac vessels are scarred down. If you're going to do that, I would recommend preoperative stenting, because if you bleed and they're stuck down, you're going to have a significant problem to try to correct that. I don't think you should do that unless you have a lot of experience with it and you have access with a vascular surgeon. We have done some intraoperative stenting, but it's you have to have the experience to do that. So stay away from that. Watch out for horseshoe kidney, renal transplants, radiation, the usual things that you would be unhappy with if you go anterior. If you're already posterior doing a direct decompression, there's no reason, unless you have a sagittal imbalance or coronal imbalance, to do anything but a nice TLIF at that level or other posterior lateral technique. And remember, transitional anatomy is not a contraindication of OLIF at all, or any lateral or anterior surgery. Not understanding transitional anatomy is a contraindication. So we've talked about that in other talks, and we can go through that again at some point in the future if you have a question. I think the best way to talk about the uses of OLIF is through this patient. This unfortunate woman with a back and leg pain, high VAS, had an unfortunate outcome from TLIF and L5S1, as you can see in the views on the right. Failed conservative treatment and obviously needed some correction. This is what it looked like up close. Degenerative scoliosis. She's had bilateral hip replacements. She has somewhat of a flat back, but not totally flat. You can see the implants at 5-1 are completely floating, and the one on the right is actually in the foramen. And so this is a lot of problems in one patient that we're looking at. So we're looking at a high SVA in this patient, although there's not a great mismatch. So this patient has pseudoarthrosis at L5S1, adjacent segment disease, L1, L4, flat back to some degree, with a sagittal plane deficiency, coronal imbalance, a right neuroforaminal stenosis, osteoporosis, high BMI, high fragility index. I think I need to send this patient to Dr. Uribe to fix this, because this is a difficult problem. But when do I use OLIF? So I'll go back to my original slide, and in one patient, you can see so many different parameters and value propositions from the anterior and lateral surgeries that can be done. It's not specific to OLIF. OLIF is just one way I do it. And so what are the goals here? To restore the sagittal balance, correct the coronal shift, repair the pseudoarthrosis, get those cages out safely at L5S1. That's a trick, to repair that pseudoarthrosis. Multi-level fusion is very important with a low complication rate. So in this case, what we did was we went to the operating room with I have a custom bed that I can go back and forth for a posterior, anterior, posterior. We started posterior. remove the instrumentation, you got to know what's going on first. So we looked at the instrumentation. There was pseudoarthrosis. We removed it and assessed the graft area. That was ideal up front. And then we could plan the screws with our robot, which was very, very helpful. We can then pack off and then go back. And now we want to do our lateral surgery. We just rotate up for the anterior component. And you can see the patient now in about 10 seconds is ready for a lateral approach in a lateral position. And then here we're going to remove the T-lift cages safely at L5S1, perform an O-lift of 5-1 to restore lordosis, and then add a more harmonic correction by doing an ACR at L3-4 and add the other additional degenerative levels for the scoliosis L1 to L4. And you can see this is the 5-1 approach. You get a really nice view. You're in a comfortable position. You're physiologically operating nicely. And you can see how nicely these cages can be withdrawn. They weren't that hard. They were kind of floating anyhow, but this is a very safe way to do it in a fast and efficient way. But more importantly, you go from a 1 degree L5S1 level to 18 degrees. And we all know 4 to 1 is where your money is for lordosis. So this is very important to get that. Now, at L3 for an ACR, we're releasing the anterior ligament. We can pick up another 10 degrees or so, which is fantastic. And now we're spreading out the correction rather than trying to do this too focally. I think that's yet another advantage. The view of it is fantastic with the third blade. Your psoas is at the top and the ACR is going to be at the bottom, right there where the suction went. You can see the ligament. You can see the anterior ligament very nicely here being taken away. And we're protecting the sympathetic chain, which almost always seems to be sitting, the major part of the chain, right on the edge of the anterior ligament. So we've learned to avoid it, and now we don't see the swollen leg issue too much anymore because we know where it is and it doesn't happen, learned. And now you can safely, in direct view, remove the ligament carefully without any concern because you're seeing everything, no blind work here at all. You could have a terrific vascular injury if you're not careful with this. And so this is just showing taking up the advantage of O-lift, getting up under the psoas and removing the rest of that annulus, which relaxes the disc space, far lateral herniations, and it makes it easier for the implants to correct the lordosis. And then you see this is another example where you have a single buttress plate with one screw out so that when you go posteriorly, you can actually rotate on that implant and get even more correction. And there's the picture of the anterior release with the implant in place. So the last part, we go back and we rotate back. It takes about 10 seconds, and we go back to finish the operation. Now that we've released everything anteriorly, the screws are already placed posteriorly, and now we want to do a little more correction on the decompression. So here posteriorly, we've done a temporary rod. We put it in because we're going to do a PCO to get more correction and to add to the L3-4 level. And I think it's just so critical to focus on, take a minute and put on a temporary rod. This is an extremely unstable procedure, which is the value. You can get great correction, you can get a great complication. And I think we've all learned from even the prone lateral that in the prone position, the advantage is you can get a nice lordosis without having to do this, or if you need it, you can do it. But you can also get iatrogenic release of ALL without desirability and maybe too much correction. So put that temporary rod on when you're doing this. And then you put your final rods, and then you see the nice correction. The SVAs come back into normal range. We've picked up lordosis in all the right places, the L4 to S1 specifically, and then globally or segmentally at L1 to S1. So the goals of restoring the sagittal balance, correcting the coronal shift, repairing the pseudoarthrosis, get those cages out safely with a multi-level fusion at a low complication rate in just 3 hours, 3.5 hours with a low blood loss. That's the beautiful part about lateral surgery. And I think that's worth taking the time to learn and make this part of your tool chest. But here's the other side. What about complications? Well, you can have vascular complications. If you add the 5-1 level to the lateral milieu, you're going to have the ALIF, basically complications. And it's a low rate, but you can have a serious complication. You have to be prepared to handle injury to the iliolumbar vein or the medial border of the left common iliac, which is where it commonly occurs. Don't see it much anymore because we're experienced, but in the beginning, you have to be prepared to take care of those complications if you have them. You can have motor neurological injury. It's rare. We don't neuromonitor any patients, and so it's extremely rare. We have no femoral nerve injuries with OLIF ever. And so I think there's a slight advantage there from the neurological side at L4-5. But we can have it, and it can happen. Urinary injury doesn't happen anymore with third blade. I think before we protected the peritoneum with the initial two blades, we had a couple of urinary injuries, and we realized you got to put a protective third blade in, and that problem's been solved. Ileus is less than ALIF, but still occurs. Retrograde ejaculation, no one even talks about this hardly anymore because it hardly ever occurs. Moving to the OLIF at 5.1 level versus ALIF 5.1, it's basically disappeared. We've had a few temporary cases, but surprisingly gone from our consciousness. So the chain problem is disappearing because we know where the chain is, the dominant part of the chain, we know how to protect it. Incisional pain can occur with the iliohypogastric and ilioinguinal nerves on the approach to the lateral side, especially at 5.1. If you know how to make the correct incision, you can avoid most of that as well. Then one patient with a distended testicle from the motor branch of the genitofemoral nerve, it can occur. I told the patient he's going to be much more powerful and strong because there's no real downside for the patient. There's no real injury. And then bowel injury can occur. I've never seen it, but it can occur with all lateral surgery and anterior surgery. And we have 2 cases of lymphocele, and it's easy to repair by opening the peritoneum, and it gets reabsorbed. Pseudohernia is never a nice thing. It's not painful, but it doesn't look good. And you can get it from the subcostal, the ilioinguinal, the hypogastric nerves. So be conscious of where they are and do your best to not injure those nerves. And then the subsidence pseudoarthrosis occurs. It occurs in all surgery, but I'll go through that with my experience that in my first 137 patients, complication rate was very acceptable at 7% or so. And within the parameters of the literature for ALIF and retroperitoneal approaches historically. Mm-hmm. And then looking now, not published, but a large series of patients, we're looking at 1,600 levels, 1,600 patients. It's still a very acceptable rate of complications, and most of them are subsidence or pseudoarthroses. Now, not so much vascular or other soft tissue injuries. The fusion rate, which is what we're all after, it's the bottom line, and sagittal balance, of course, in the beginning, very good, just like we would expect from ALIF or retroperitoneal surgery. We always had high fusion rates. This is not a surprise. And it's nice to know that after all these years and now almost 4,000 levels of OLIF, we have an extremely high fusion rate as we would expect. We're actually getting a little better over time. So I just want to end this with what have we learned over all this time with OLIFs? It's a very safe, reproducible, highly effective procedure for most lumbar pathology. We have an extremely high fusion rate. And remember, that was our goal. When I started in spine surgery, getting a fusion was a big deal. And now I expect it. Significant indirect decompression is still the beautiful part about lateral and anterior surgery. And limiting the need for laminectomy is fantastic. Complication rates are acceptable and within the purview of the literature and low, and excellent patient outcomes, a very MIS approach. I want to thank the Seattle Science Foundation for letting me have this opportunity to talk with you about something I have passion for, but I still feel that now as a family of lateral surgeries, all used in the right appropriate time and place, have fantastic utility for the future. Thank you very much, Rod.
So Rick, that was terrific. Appreciate your experience, and I think it's a very unique approach to accessing 5.1 and 4.5. Can you give us just a little bit of insight into, because I think your experience is obviously you've done a lot of these and you make it look so easy. What's your do you have some advice on, people starting to do this, like their first 5 cases? Obviously, you shouldn't start by doing L5S1, right?
Absolutely. Yeah. I think, the way to look at it is lateral surgery, L1 to L5 is where a lot of the work is done. And you don't have to do L5S1. It's that it can be done safely. So it could be something out there as a goal, and it's something you want to achieve, something you want to learn. I would definitely start with a vascular surgeon. If you haven't done ALIF, if you're experienced with ALIF, it's really just a lateral ALIF. So that's a great point, Rod, that the 5-1 is not a snap. It's something you learn over time. And it's nice if you can add that, because then you can do all the levels in one single position, which is great. And of course, we know that the dominant amount of lordosis that we want and need comes from L4 to S1. And a lot of it's L5 S1. So getting lordosis of 5-1 is the key value to doing the O of the 5-1. At L4-5, I mean, we're avoiding the femoral nerve. That's the greatest advantage. But I think you get great lordosis with transmuscular anterior to the psoas. They're excellent. They're both excellent. And now TLIF even is getting better with expandable cages at getting lordosis. But I still think that the advantage to the OLIF 5-1 is there, but it has to be learned. You have to be careful, and then make sure you know how to repair a vascular injury.
I think Adam has a question, but I think those are great points, Rick. Adam.
Quick question. Thank you. Great talk. You know, you talked a little bit at the beginning. You said that you're not solely committed to the pre-psoas approach. Sometimes you do go through the psoas. And I guess one question I would have, I'm going to be giving the trans-psoas talk, is can you describe when it is that you transitioned from trans to pre-psoas, if that is the case? And why specifically, what you feel the advantage is over trans-psoas. I think that's interesting as people make that transition.
Yeah, thank you, Adam. I did definitely started trans-psoas. Well, I actually started anterior to psoas. My training was open, big giant retroperitoneal approaches for tuberculosis. So we started anti-psoas. But then when Dr. Pimentel and Dr. Uribe introduced the transmuscular, we jumped right in. It was a great advantage over going ALIF at L2 to L5, but much better. And so what happened was we were having problems at L4-5. We were just difficult getting around the crest and that. So one day I said, well, why don't we just go anterior to the psoas there and retract it like we used to do? And okay, we did that, and it was fine. And we realized, wait, this is easy. Believe it or not, it was 300 cases later when I stopped doing trans-psoas. I would literally do anterior to psoas at L4-5 and go right trans-psoas through 3-4-2, 3-1-2. And it was my access surgeon that said, well, I don't understand why you're going in front of the psoas at L4-5, but you're still going through the psoas at the other levels. Why do you do that? And I couldn't answer him. And so that was the transition. I realized, well, wait a minute, we can obviously, there's a corridor. We went and did some cadaver work, realized the corridor's there. There's a nice space there. In fact, the hardest space is L4-5. The other spaces are much more easy to go anterior. And then we realized, there was this cost savings without the neuromonitoring. I've neuromonitored the OLIF for years. And it just, the thing was asleep. There was no signal, there was no sound. And then I monitored the saphenous nerve for femoral injuries. And finally, you realize that there's nothing happening when I retract the psoas. Even under monitoring, the femoral nerve's quiet, the saphenous nerve's quiet. And so realize you can retract, you can rotate. The nerves are very happy moving around inside the psoas. And so, but once again, I'm not really pushing you have to go to psoas, go anti-psoas. I think transmuscular is an excellent approach, and I think there's utility for both. I use it specifically for infection. If I have a patient with a discitis and I'm going to fix it, I'll go a trans-psoas approach on the right side, put my implant in after I take out the infection with antibiotics and maintain the balance of the spine. I'll put the implant in reverse so that I'm ready to come back on the left side when I'm ready. And after antibiotics, I come back on the left side through a little incision. I do an OLIF and pull that implant out and put in a fusion implant. Now, you could do it all in one step, but if you want to be 100% sure you're not going to end up with an infection in your fusion, that two-step approach has worked out beautifully. Two small approaches, 6 weeks apart, and getting, we get a lot more infection here in tropical zones than we get in the rest of the country. We get 10 to 20 a year, every year. And so it's become a great way to handle infection for me.
So Dr. Hynes, again, for the participants and the audience, so when the main reason that you use pre-psoas is just not because you want to save money and not to do monitoring, yeah? Because as you know, monitoring is becoming a gold standard in many countries in the world, and even ACDF single level has been monitoring all the time. So besides the not, trying to, obviously, which is good to have some health, money saved for the health system, when do you see that the pre-psoas and the Prepsoas do not compete? In other words, is for the participants, when do you think Prepsoas is amazing, and when do you think Prepsoas is amazing, or you think it's just more dealer choice than anything else? That probably was also part of the Adam question, correct, Adam?
Yeah. I've heard of some folks that have transitioned from the Prepsoas to the Prepsoas, and I've done a fair number myself, but I tend to stick with the Prepsoas, and perhaps it's just because of my long history and comfort with it. But it's interesting. I don't know if many folks that have transitioned from Prepsoas to Prepsoas. It's typically a one-way street, and I'm always curious to talk to those and get the perspective of someone like yourself who has made that transition and why. And it seems like the answer is very often the same: is whatever you're comfortable with. They both are very safe procedures. What you're comfortable with, and that's what you found.
I think for me, it's a subtle difference really now, because we're all experienced. In the early days, we were learning a lot, and there was a lot more complications with Prepsoas in the beginning, like any operation. But now, it's just, I'm used to it. And I think at L4-5, it has an advantage. There's no iliac crest issue. It doesn't matter how high the iliac crest is. It doesn't make any difference. You can always approach that through an OLIF. And I've never had to abandon a 4-5 level. And then avoiding the femoral nerve. I think I had a femoral nerve injury in a patient who was almost a semi-professional tennis player, and it ruined her career. Ruined it, and she had a shrunken thigh. And I got a bad taste in my mouth early on with a bad injury, which directed me out of the Psoas. I actually call her Miss Olif, and she said, "Why did you switch the operation?" I said, "Because of your injury." I didn't do anything wrong. It was early learning, and I wanted to avoid that. So I think there's an advantage there. We don't see any injuries. We've never seen one with Olaf, because you're really outside the psoas. Those are the two big areas, but I think also the view and the exposure without having to split the psoas for the anterior ligament release is lovely. I mean, I put that third blade around the ALL every single case, because if you do it every time, it's simple to do when you want to release. But I also do it so I can see the anterior ligament and not injure it when I don't want to take it, when I want to preserve it from ligament ataxis. So I think these are all subtle, small advantages. Femoral nerve injury is a big deal if you get one. Thank God we don't see it that much. But once again, the transmuscular approach done the correct way is an excellent procedure. And so maybe it is coming down to training, teaching, and where are you comfortable. There are subtle differences. And then of course I like the 5-1 approach, and that's not for everyone to do a lateral ALIF. That's for those people who are trained in ALIF, or you want to learn it and you have a vascular surgeon. And I think adding that to the other OLIF, we're staying completely out of the psoas. We're not neuromonitoring. We're getting all levels in one position, and we have access to the anterior ligament. It's probably the best way for me to summarize that.
Juan, I wonder if Juan and Rod, I wonder if you guys are about to do the bioskills lab and show, with the endoscope, the approach. I wonder if while you're down there, if it's possible for some to see, as Richard just explained, that a lot of this is just understanding an anatomy and seeing how it's done. And I've seen 1,000 courses where we've seen the Prepsoas approach, and we actually see that. But I don't know that I've ever watched anyone, on live show, and maybe you've done it, Rod, and I just haven't seen it yet, but show the Prepsoas, while you're down there, if you can show us releasing the psoas muscle and translating it posteriorly, that would be, I think, useful.
Yeah, really good point, Adam. So what we can moving on our presentation. Now I want to make sure that Rod is going to be moderating the Dr. Lynch demonstration. But more than anything, I want to give you a little bit of a statistics, what's happening right now with the course. We have 91% of the participants, actually, they are physicians, MDs or DOs, and we have 48% are neurosurgeons. The rest is orthopaths, and we have actually 68 countries participating right now. And the top 5 countries, if you like a little bit of trivia, where are we at right now? Obviously, number 1 is America, US. Second one is India. Then we have Brazil. Then we have United Kingdom, and then the last one on the first top 5 is Mexico. So this will be changing through the day that we've been noticing lately, but it's very interesting. And also most of the participants are actually physicians that are within their first 5 years. We love it, because what our goal is to indoctrinate as much as we can surgeons into the anterior lateral surgery. We want to fresh meat. So, Rod, now we move to the lab.